Hello, everyone, and welcome back to another Rafael Medina Subspecialty Virtual Morning Report. Today, our focus will be on cardiology, and for this, we have two amazing guests. As a case presenter, we have Dr. Maulin Shah, who is a PGY6 third-year cardiology fellow at Sinai Medical Center. He completed his internal medicine residency at Sinai and will be starting electrophysiology fellowship at Stanford in July. And okay, you can still hear me, okay. And as a case discussant, we have a very well-known person within the CP Solvers community. Everyone knows her. It's Dr. Michelle Kittleson, who is professor of medicine at Sinai and director of education and heart failure and transplantation at the Smith Heart Institute. She completed residency training at Brigham and Women's Hospital and cardiology fellowship at Johns Hopkins, where she also received a PhD in clinical investigation. She is interim editor-in-chief of the Journal of Heart and Lung Transplantation and serves on writing committees for guidelines on hypertrophic cardiomyopathy and heart failure. And she is the co-editor-in-chief for the ACC Heart Failure Self-Assessment Program and on the board of directors for the Heart Failure Society of America. And her essays have been published in top medical journals like New England Journal. And she also has written a book that is titled Mastering the Art of Patient Care. So before we start the session, I would first hand the mic to Dr. Maulin and to Dr. Kittleson to tell us why they chose cardiology and what they like to do outside of medicine, and also to Dr. Kittleson to tell us something about her book also.
I'll go first, I guess, Maulin. Is that okay? So
yeah,
what do I like to do outside of medicine? Well, my two other hobbies are wild animal wrangling and hostage negotiation, or else that's how it feels when I have 3 kids at home. So that's my other hobby besides being a cardiologist. I chose to be a cardiologist because I love the fact that the history and physical matter. You can't diagnose unstable angina without a history. You can't diagnose heart failure without a physical exam. I love the fact that there is a strong evidence base to guide what we tell patients to do. And I love that my job involves all kinds of different things every day, crashing and burning shock all the way to chronic management in the clinic. The variety keeps me very interested and engaged. And my book is, I don't always carry it around with me, but I'm doing a reading right after a session we have right now. So my book, Mastering the Art of Patient Care, is based on all my mistakes and the wisdom of my mentors, because life's too short to make all your mistakes yourself. Learn from mine and be a better doctor. So that's my take. I'll hand it over to Dr. Maulin Shah.
Thank you, Dr. Kittleson. Outside of medicine, I love running. I like running for sport, and then also running and chasing my 18-month-old and my 2 beagles. I chose cardiology for a lot of similar reasons. I love that there's always an imaging finding that is associated with the physical exam finding that you can always confirm. I love the patient population. It's very old patients that are very sick, and there's also very young patients that maybe have an arrhythmia that can be cured. And I think another thing I really like about cardiology is a lot of the aspects are curative. If we can put someone into an AVNRT ablation and totally cure them, which is not necessarily true of all specialties. I also like that you can make a lot of analogies with the home. I love HGTV. So I like how the heart has doors, it has a plumbing system, it has an electrical system, and it has walls. So that's what I love about cardiology.
Amazing. So first of all, thank you both so much for being here. We are so delighted to have you with us, and I hope we can all go over our cardiophobia that we had, because I remember, if you haven't checked out, we once had an episode with Dr. Kittleson about cardiac amyloidosis, so you have to check it out. Then you will be a master in amyloid. so Gia, if you are ready and could share the screen with us so that Dr. Maulin can start with the first aliquot. Okay, Maulin.
Right. All right. So the chief complaint is shortness of breath and dry cough. So we have a 19-year-old female with no significant past medical history who's presenting with 2 months of progressive dry cough and shortness of breath. She described it as a tickle in her nose and throat that produced a cough reflex. She stated that it was worse when lying down and associated with shortness of breath. She was initially treated for a presumed community-acquired pneumonia by her PCP 5 days prior to admission, but with no improvement after 5 days, she was advised by her PCP to present to the hospital. On arrival to the hospital, she endorsed morning headaches for several months prior to the onset of her cough and shortness of breath. She described them as located in the frontal area and throbbing, and occasionally associated with vision changes and tinnitus. She also endorsed joint pain and muscle pain that was not responsive to over-the-counter medication. She endorsed nocturia, exertional fatigue, decreased appetite, and weight loss. She denied chest pain, palpitations, recent travel, sick contacts, hemoptysis, fevers, chills, night sweats, or abdominal pain. She has a history of seasonal allergic rhinitis, but no other significant past medical history. She has no previous surgeries and takes no medications. Her father has type 2 diabetes and asthma. She has 2 siblings with no medical problems. There is no known history of autoimmune disease in the family. She denied any tobacco, alcohol, or recreational drug use. She was not sexually active and was a student in college. So that's the first aliquot.
So, Dr. Kittleson, we have a very enriching aliquot. The first question I would like to ask you is there any kind of center of gravity in this aliquot so far, and how would you approach it? So what are your initial thoughts?
Such a good question. So, I always thought the scariest thing in medical school was learning differential diagnosis, right? You spend the first 2 years reading textbooks, you read about diseases. But patients don't have diseases, patients have symptoms, and you have to learn how to work backwards. And the best way to think about it is that we organize our etiology by pathophysiology. You don't memorize a list of things, you try to reason out a list of things. And you're right, which symptom am I going to focus on when I'm thinking about where do I organize my differential? Well, of course, I'm a cardiologist, so I'm going to focus right in on that shortness of breath. And from what I gather from what Dr. Shah is telling us, she showed up to the ER. So if I think of which of these symptoms actually was the trigger that made her go to the ER, it's likely the shortness of breath. Okay, let's start with shortness of breath. What do we think about? It's either the heart's fault, or it's the lungs' fault, or maybe it's something else strange like anxiety or neuromuscular disease. But let's put those things aside for a minute and say it's the heart's fault or the lungs' fault. Then we think anatomically. Well, if it's the heart's fault, it could be the arteries. Kind of weird in a 19-year-old, but who knows? She could have some anomalous coronary something or another. She could have, God forbid, a dissection of some kind. And we think of the muscle, cardiomyopathy, my life's work, the thing I understand more than anything in the world. Something electrical might make you short of breath, but again, she has no palpitations, or it's more progressive than paroxysmal, like you think about for an electrical type of thing. You think about the pericardium, the sac around the heart, but again, a little weird for 19 to have something going on there, and you wouldn't expect solely shortness of breath. So when I think about the heart, I'm thinking mostly about the myocardium. We can't forget the lungs too. There's the parenchyma, there's the pleura, there's the airways, there's the vasculature. Certainly something could be going on there, but again, since I'm a cardiologist, I'm going to think a little bit less about that. And then we have to think about unifying diagnosis. Like, what else is going on? Is she just stressed, so she's getting headaches? Is she just, kind of young and she's just feeling joint pains? Or is there something underlying and unifying that is either rheumatologic or endocrine or neuro? I don't have enough sense yet, but that's what I'm thinking.
Thank you so much. And in this case, what I have heard, the patient also has morning headaches. And also what I have heard so far, joint pain and also vision changes. Is there something that would change your differential into one direction?
Oh, there probably should, but I'm totally blanking. And I always say you don't have to know the right answer. You have to know how to find the right answer. So I might even go to Dr. Google and type those 3 things and tell me what it told me. But okay, morning headaches, I think sometimes of like sleep apnea can give you headaches. Morning headaches, sometimes you worry about some brain occupying lesion. But she's only 19. We don't want to get too dramatic here. And then the tinnitus and the vision changes, like a pituitary adenoma. Is that compressing on her optic chiasm? So there's something strange going on. And then if you add the joint pain, does she have a lupus cerebritis, and then she's getting a nephritis, and she's getting high blood pressure? So I agree, it's too much right now. So I feel like we need to anchor on one thing Is there something serious or dangerous? Why she's short of breath? And then fan out from there.
Thank you so much. Then Dr. Maulin, would you like to share the next aliquot with us?
Great. Thank you, Dr. Kittleson. That was amazing. So her blood pressure on arrival was 172 over 106. Her temperature was 98.2 degrees Fahrenheit. She had a heart rate of 112. She had a respiratory rate of 26. Her oxygen saturation was 100% on room air. She was 98 pounds and 5'1" with the BMI of 18.5. On exam, she was ANO times 4. She was in some distress, but minimal distress. For head and neck exam, she had no oral lesions, no adenopathy. Her jugular venous pulse was measured at 12 centimeters. Her lungs, she had decreased breath sounds in the lung bases bilaterally, and also mild crackles bilaterally up to the mid-lung. Her cardiovascular exam was tachycardic with a regular rhythm, and no murmurs, rubs, or gallops were appreciated. Her abdomen was soft, non-tender, non-distended with normal bowel sounds. Her extremities were warm and well perfused. There was no lower extremity edema. She had multiple small 1 to 2 millimeter excoriations with overlying eschar on her right lower extremity and 2 similar small lesions on the left lower extremity. She also had hyperextension of her elbow and wrist joints. Her neuroexam, her cranial nerves 2 through 12 were intact and otherwise had normal strength and sensation throughout.
Thank you so much, Maulin. So summarizing what I see so far, we have hypertension, elevated JVP, tachycardia, also crackles in the lung, and some skin lesions. So Dr. Kittleson, what would you make out of all the information?
Yeah. Okay. So I'm focusing on that hypertension, first of all, because a 19-year-old might be stressed out by being in the ER, but they're not going to be that stressed out. That is not a normal blood pressure. So why is a 19, and she's not obese. I mean, you maybe could argue, oh, someone who's obese, and I know she was 98 pounds, her BMI is 18 and a half. So something very strange is going on. She also has these excoriations. She's got this hyperextension. So I'm thinking about something collagen vascular. So let's think about a collagen vascular type condition that may give, and I wonder on our abdominal exam, did she have any abdominal bruits? Does she have some kind of renal artery stenosis? I mean, that's not very sensitive, but she's so thin, you kind of wonder. It's also not very specific. So this is smelling to me like something connective tissue vascular. And how could we explain it? She's got really bad hypertension from, say, renal artery stenosis, which has led to heart failure symptoms because she clearly has elevated JVP, decreased sounds at the basis of pleural effusions and pulmonary edema, and then some kind of skin fragility that's leading to these issues with excoriations. Does this vascular issue now also go to her head, and there's something funny going on in her head that's leading to these headaches? Now, the morning headaches could be the hypertension, but is it also, with the vision changes and the tinnitus, something going on with her brain vascular bed? So I feel like we're honing more and more onto the vascular system. I suppose you could also say a hypertensive, reversible, treatable causes of hypertension in someone this young. I mean, I suppose thyroid storm, but it's hard to explain everything based on that. Cocaine, never assume, right? Could she be having some kind of cocaine type crisis? But again, that doesn't necessarily explain all of her symptoms. And pheochromocytoma, she seems kind of young to be entertaining that diagnosis. But so that's where my mind's going. High blood pressure, what are the secondary causes? What secondary causes fit with her other presentation and would be more common at her age?
Thank you so much, Dr. Kittleson. That was amazing. What I also wanted to ask you, since you mentioned these collagen vascular diseases, so what comes into your mind? Because I remember something like Marfan and Ehlers-Danlos, but I have to say, I really don't know how to differentiate it, so would like to learn from you.
You know, I have to tell you, this is something I look up all the time. When I have a patient refer to me for a question of one of these conditions, I'm a big believer in advanced preparation. I review all the records in advance. I prep my note and I go and I read about it. And I either find a recent scientific statement from the ACC or AHA, or I find a state of the art review article that was published in Circ or JAC, or I go to up to date. I try to get, now Marfan's is so tricky. There's like all those criteria, the Ghent nosology. I don't even know where that term came from, but it's really hard to diagnose well, ectopic lens, hyperextension, thumb sign, wrist sign, span, the pes planus. I mean, there's so many things for Marfan. Ehlers-Danlos and genetic testing is yet one part of it, but not necessarily positive and not necessarily a smoking gun. And then Ehlers-Danlos, more of the vascular connective tissue. There's different types. There's the hypermobile type. There's the vascular type. But in both those conditions, typically you worry about the aorta. You worry about aortic dilation. And if you have aortic dilation, that shouldn't give you any symptoms. In fact, that's like you're a ticking time bomb. You need surveillance of your aorta. You have an aortopathy. This, when I hear about things like the high blood pressure, and I hear about things like the brain symptoms, I'm thinking more of like a fibromuscular dysplasia affecting multiple vascular beds. But I don't know. Like I said, it's okay if I'm totally wrong, because you gotta know how to reason out the case and look for the right answer. Keep going.
Thank you so much. It was amazing. What I also wanted to ask is, the patient also has these skin lesions. What I have read out, there are some Escher-like skin lesions too. Do you think that this is more signal or noise? What would you make out of this?
Now let's think about this. I mean, listen, if she's using cocaine and she's using other drugs, maybe it's a sign that she's got some kind of, really concerning, illicit substance use that's coming through. That's, I suppose, one possibility. The second possibility, it's something related to a connective tissue disease. Now, then we think of infiltrative cardiomyopathy, sometimes have like angiokeratomas, can be in things like Fabry's, but this doesn't sound like an angiokeratoma. I don't know yet. I don't know. I'm going to reserve that in the back of my mind and say maybe it'll be an aha moment of a unifying diagnosis. It doesn't even sound to me that that's something I'm going to dive after with like a skin biopsy yet. I want to get more information.
Thank you so much, Dr. Kittleson. Then, Dr. Maulin, would you like to give us the next aliquot, please?
All right. So I'm going to go through some labs here. For CBC, her white count was 11.5, is neutrophil predominant. Her hemoglobin was 9.9. It was 11.2 about 1 year prior. Hematocrit was 31.9. Platelets were 454 and was 562 1 year prior. Her BMP, her sodium was 136. Her potassium was 3.1. Creatinine was 0.8. Her ALT was 66. AST was 53. Her ESR was 55. CRP was 12.7. Troponin was 0.11. Her BNP was 2,734. Lactate was 0.7. She had a 6 a.m. aldosterone level that was 12 nanograms per deciliter. Renin activity was 26 nanograms per milliliter per hour, and the ratio was slightly below normal. Her AM free cortisol was 580, the normal range of 3.5 to 87. And her ANA titer was 1 to 40. Her anti-double-stranded DNA was negative, SSA, SSB negative, Smith antibody negative, rheumatoid factor negative, scleroderma antibody negative, and complement values were within normal limits. She also had a UA that was within normal limits. Her sexually transmitted infection panel was negative. Her urine tox screen was negative, and her viral panel was negative.
So, Dr. Kittleson, what would you make out of all the new information?
I'm so confused. I'm just going to tell you, this is weird. I mean, why is she so anemic? Why is she hypokalemic? Why is that troponin? Why is her ESR and CRP high? I'm confused. Okay, so what we can rule out, the ANA is kind of like a whatever. We're going to throw away the ANA. We're going to throw away the double-stranded DNA. I think we can say we're going to take lupus off the table, which is fine because we weren't really considering that. I have to remember now the AM cortisol being high and the plasma renin aldo, was that abnormal, that ratio?
It was slightly below normal,
Okay.
but I
Okay.
don't think
Got it. So nothing to
crazy
write home
abnormal.
about. So you got this high AM cortisol, which to me, I don't check a lot of AM cortisols, but it seems to me that this is very interesting as a sign of like a Cushing type picture. And there's the Cushing's that you have where it's coming from the pituitary, like it's Cushing's phenomenon, or Cushing syndrome. One of the ones is from the pituitary. So is she overproducing cortisol? But then why would she, and then is there also some kind of mineralocorticoid excess kind of in with that, which is why she's having the hypokalemia, and that would also explain her that would explain her hypertension, and then her hypertension could have led to her heart failure type symptoms. So I'm going to be very interested in a number of things right now. Number one, I do want to see her echo at some point. I'm sure hope she had one because I would just feel so comfortable with an imaging test I know how to interpret. Number two, I would call my favorite endocrinologist and say, something weird's going on here. I always call you for borderline AM cortisols. You always get irritated with me. What do I need to do now? Do I need to do is it a court stim test? Do I need to check an ACTH? Do I need to figure out if this is coming from somewhere in the hypopituitary axis? There's something endocrine going on. I'm not an endocrinologist. So I want to hone in more on the endocrine things. Then I wonder if she's got, you didn't give me any of the classic skin striae, moon phases, weight gain, central obesity, but is some of her skin stuff just skin fragility and now leading to issues? So I'm anchoring very tightly onto this high cortisol. And I don't understand the anemia, but it's weird too.
Thanks for this masterclass discussion. What I also wanted to ask is, we see that this BNP is very high. What would you make out of this?
I feel like the heart's the innocent bystander in this whole process at this point, let's be frank. The shortness of breath brought her here. I think the shortness of breath is likely driven by the hypertension. She's gotten some kind of a hypertensive cardiomyopathy, which may have led to some stress response with the troponin. I'm not like now chasing down a myocarditis pathway. It's just not high enough to make me think of that. And then the BNP, again, so the heart's an innocent bystander. It's really freaking out from the stress of this super high blood pressure, and the BNP goes up. So I think it's not a medical mystery here that I think her high JVP, her edema, her crackles, her pulmonary edema, all of that is coming from a cardiac source, and that cardiac source is coming from her hypertension. But now I want to figure out why she's so hypertensive. I think that's where we're narrowing down to.
Thank you so much. What I also wanted to ask is regarding the heart failure, like how do I differentiate between hyperacute or acute heart failure? Like in this case, I would tell that this patient has some decompensated heart failure. And if you go through differentials for something like hyperacute heart failure, are there some things that you always go through, like management-wise, like these are some things that I definitely have to exclude before we go to the esoteric or rarer stuff?
It's a good question. I'm not sure if time course is always helpful. I think time course can be misleading, especially in a young person. I'm not saying that's this patient, but I have seen patients who come in and say, I was playing basketball a week ago, and then they're in the ICU in shock with an EF of 10% and a left ventricle of 8 centimeters. You said, this is not an acute process. This is a chronic process, because young people can compensate for a very long time. So when I think about the differential diagnosis of underlying causes of heart failure, I look at two things. I look at the echo, because your differential is going to be different if you have heart failure with reduced EF or with heart failure with preserved EF. You're going to be thinking about a different list, and the age and demographics of the patient. So if you have a 60-year-old with hypertension, diabetes, dyslipidemia, ischemic cardiomyopathy is going to be top 1 through 7 on my differential, where I have a 19-year-old who might have the exact exactly the same echo, I'm going to be thinking more of, idiopathic, which in 30% of the cases at least is actually familial genetic. And remember to take a 3-generation family history, not just a 2-generation, because some of these things have autosomal recessive or variable penetrance and expressivity. So if you really want to pick a pattern, go up to 3 generations. And then I think about, so genetic for sure. And of the non-ischemic causes, think also about the toxins, particularly cocaine and methamphetamines. Think about the weird endocrine things like hyperthyroidism. So I think your differential is more by echo and demographics than by the time course of presentation in most cases.
Thank you so much. And now to make much more progress with this case, is there something that you would like to order or do?
Since I'm allowed to phone a friend, that is because medicine is a team sport. And you always have to, you never are ashamed to look to friends for the answer. And there's a lot of really smart people who I feel like are sort of pinging me with advice and from various places. So I would say if there's other things I would want to do, I would call my friendly endocrinologist first. And if I call my friendly endocrinologist, he might ask me to do a dexamethasone suppression test or free urinary cortisol. Again, this is totally out of my comfort zone. And you don't have to even know the right answer or where to find the answer. You have to know how to ask the right question. So my question to the endocrinologist would be, are you scared about this cortisol? And if you think it's real, like I think it's real, what do we do next to figure out the source and then treatments? And you pick them down, they tell you what to order. And then as soon as the tests come back, you harass them again to figure out next steps.
Thanks a lot. I learned so much from our discussion. Then, Dr. Maulin, would you like to give us the next aliquot, please?
Absolutely. So the next aliquot, we have some test results. We'll start with the chest x-ray, mild cardiomegaly with moderate pulmonary edema, small bilateral pleural effusions, partially loculated on the right. For the transthoracic echocardiogram, we have a mildly dilated LV, an LVEF of 15% with global hypokinesis. We have an LV septum and a posterior wall thickness of 1 centimeter at end diastole. We have multiple left ventricular apical mural thrombi. We have normal RV systolic function, and we have a dilated and less than 50% collapsible IVC, consistent with the elevated right atrial pressure. For the EKG, I think we have an image of it, but it was sinus rhythm at a rate of 93, PR interval of 114. QRS interval of 84. QTC was 544. It was read as biatrial enlargement, large QRS amplitude in V2 and V3, and then diffuse symmetric T-wave inversions in V2 to V6, as well as in 1 and ABL, consistent with a repolarization abnormality. We also had a CT angio abdomen pelvis, which showed an abnormal contour of the upper abdominal aorta, had severe stenosis or short segment occlusion of the left renal artery with global hypoperfusion, multiple areas of abnormal enhancement within the right kidney, which may be infarct. There's a question of non-occlusive embolus within the distal internal iliac artery on the left. We also got a cardiac MRI, which showed an LVEF of 27%, minimal late gadolinium enhancement, minimal presence of epicardial edema, diffuse pericardial inflammation consistent with perimyocarditis, and less likely infiltrative cardiomyopathy. And then she also got a left heart catheterization, which showed no evidence of epicardial coronary artery disease.
Wow, so many information. So, Dr. Kittleson, what would you make out of it?
Okay, so her EF's really low. Her LV is not thick by normal standards, maybe 1 centimeter, but it's kind of thick for a 19-year-old, and she's got some voltage criteria or EKGs. I think this hypertension, I still think, is driving a lot of what's going on. The fact that she's got all those mural thrombi in her left ventricle, whenever I think about tons of thrombosis, I'm like, ooh, is there something really weird like Leffler syndrome, endomyocardial fibroelastosis? But I'm like, you know what? Come on, how many diseases am I going to give this poor woman? She could have like chronic hypertension leading to a hypertensive cardiomyopathy, and with her low EF developed thrombus. And while it's kind of, oh, she's got a left renal artery stenosis, maybe that bruit was there all along. No, I think it's all emboli. She's got emboli from her heart that's going to all kinds of vascular beds. The MRI is interesting. I mean, I don't know what to make of this perimyocarditis. I mean, so much of the time, as we get more and more MRIs, our ability to see things, I think, outstrips our ability to know what to do with it. So am I going to go and reorient my entire differential and hang my hat on perimyocarditis on the MRI? I mean, her troponin wasn't as high. This does not smell like a rip-roaring myocarditis driving this process. I mean, it's quite impressive, isn't it? You have someone with an EF of 15% generating a systolic blood pressure of 170. This blood pressure is driving this process. I know the ESR and CRP are high. Maybe there's some form of a cortisol producing entity that leads to an inflammatory state. I'm totally waving my hands, but I'm still saying that I think that the thought process here is something, maybe a cortisol driven process, took that blood pressure up. That high blood pressure then led to the cardiomyopathy. That cardiomyopathy led to the LV thrombus. The LV thrombi then led to the embolic phenomenon. And hey, congratulations, Maulin, by the way. I didn't know you're going to do EP fellowship at Stanford. Go Stanford. It's great. But no offense to you and your EKG. I don't think that tells me much of anything. I mean, she's in sinus rhythm. She's got a little voltage criteria. She's got some T-wave inversions. It's an unhappy heart as reflected in an unhappy, but non-specifically unhappy EKG.
Thank you so much, Dr. And what I also want to say is regarding the MRI findings.
Sorry, the what? The MRI findings. Yes, yes.
Yes, exactly. Because there is this late gadolinium enhancement. I am so terrible at interpreting cardiac MRI. So what does gadolinium enhancement say us?
Yeah, so there's pretty minimal LGE, late gadolinium enhancement, Maulin told us. It's really essentially a sign of a potential infiltrative cardiomyopathy. So when you get a cardiac MRI, you're looking for a number of things. You're looking for a potential something like amyloidosis, or you're looking for a hypertrophic cardiomyopathy, or you're looking for something like a myocarditis, or you're looking at the pericardium. So really, that's why you you kind of go in lots of different directions. To me, I wouldn't have thought amyloid anyway, but okay, we've ruled out amyloid. We weren't thinking about HCM. There's clearly none of that. But again, I really kind of feel that this perimyocarditis in a way might be a distractor. And what are you going to do about it anyway? I mean, what are the types of myocarditis we actually care about? We care about giant cell myocarditis because that has an absolutely horrific prognosis, and it's the kind of thing you might list someone for transplant yesterday and you would biopsy to document, to prove it and go forward. Lymphocytic myocarditis, viral myocarditis, there's no real data that treating it makes a difference. So I certainly, and when do you biopsy someone? So you biopsy when you think it's giant cell. When do you think it's giant cell? When they present in crashing and burning shock or recent heart failure with weird things like a ton of VT or heart block. Having none of those things, again, I'm sort of sitting on that finding and feel like once I better understand the cortisol, maybe the MRI findings will make more sense to me.
Thanks a lot. And I was, also very concerned of these thrombi that we saw. As you mentioned, something like eosinophilic myocarditis is very prone to present with the hypercoagulability. And do you think that also the Cushing may be a driver for this hypercoag state? And if so, is there any mechanism for it?
Yes, well, I would have to look that up. In all honesty, I like I said, I still feel like the high blood pressure, the cortisol, there's something Cushing-like driving this. But when someone has a really low EF, and they've had a really low EF for a while, thrombus can form anyway. We just see that in general. So I don't know, that may make sense to us in retrospect once we put this all together, but I'm not sure it helps me balance my differential.
Thanks a lot. And I was also asking myself, going much more forward with this case, what would you do like for management and also for, for the diagnosis of this case? Because I was asking myself in terms of myocarditis, I remember the definite diagnosis is being made with biopsy, but I think we don't always do endomyocardial biopsy. So I wanted to ask you what you would do in this case.
Yeah, there's a nice scientific statement came out a few years ago on who should you biopsy. And it's basically you should biopsy people who it will change your management, which includes essentially two categories. They're in cardiogenic shock. So you're worried this could be giant cell because giant cell, a biopsy diagnosis of that is an indication for immunosuppression, as well as consideration for a heart transplant because they often don't do well. The second reason you might consider a biopsy for myocarditis is if they have new onset heart failure, so just a few weeks to months, with something weird like VT or heart block, which tells you there's something else maybe different going on. There's other reasons why you biopsy, like amyloid, totally separate. But I think typically in this day and age, we often start with the MRI, which is incredibly helpful in guiding us towards or against myocarditis, and then guiding you on whether you need a biopsy. But again, like I said, in this case, it just doesn't smell like this perimyocardial inflammation is the driver of the process. It's somehow along for the ride. But again, I'm anchoring on that cortisol. That cortisol at this point does not make sense to me. That can explain the hypertension, it can explain the heart failure, it can explain the LV thrombus. So I want a better sense.
Thank you so much, Dr. Kittleson. That was amazing. Then, Dr. Maulin, would you like to give us the next aliquot, please?
Yes, so this is the last aliquot, so it will reveal the diagnosis. So a lot of consultants or a lot of teams were consulted. Ultimately, the recommendation was to get an MRA chest based on the CT angio findings. So an MRA chest was done, which showed mural enhancement of the mid-abdominal aorta and the proximal renal arteries, focal moderate stenosis of the distal thoracic aorta, mild diffuse mural thickening of the aorta at the distal arch through the abdominal aorta, 50% stenosis of the proximal right renal artery and occlusion of the proximal left renal artery with reconstitution, persistent segmental areas of infarct in the right kidney and global hyperperfusion and atrophy of the left kidney, and greater than 50% stenosis of the origin of the SMA. So I won't say the diagnosis just yet so that Dr. Kittleson can talk about these findings.
So we started out by saying there's some vascular issue, because she's got this brain stuff and she's got this high blood pressure. It smells very vascular Betty. And now if we say, her ESR and CRP is high, she's got an inflammatory vascular Betty kind of issue. And then if you take it's either small vessel vasculitis, medium cell vasculitis, or large vessel vasculitis. This to me seems to be in our medium to large vessels. So Takayasu's comes to mind when we think about this arteritis, but I'm still confused by the cortisol because I still don't understand why that's elevated. But I think this woman has Takayasu's arteritis, needs an endocrine consult, rheumatology consult to tell me how fast do I give her steroids.
Thanks a lot for this amazing discussion, Dr. Kittleson. As you also mentioned about vasculitis, as you said that this seems to be more something like of a large vessel vasculitis. Is there anything that makes you think because we also see involvement of the renal arteries and of the SMA, which we consider as medium vessel vasculitis. How can we, differentiate whether this is large vessel or rather a medium vessel? Yeah.
Oh man, the cardiologist is the worst person to ask that question to. Call the rheumatologist. No, I think at this point, and this is my questions for the rheumatologist are going to be, are the imaging findings enough to make your diagnosis? Is it like, I know temporal arteritis, we biopsy the temporal artery. Do you need to biopsy something? I'm very satisfied by this outcome, except I still want someone to explain the cortisol to me. I think the high blood pressure is because she's got all this vascular stuff in her kidneys. Who knows what, she's got some brain kind of aneurysms going on that's giving her all those neurologic symptoms. And then pretty much everything else can be explained by the fact that her heart. Now, does she have a primary? I don't think she has any coronary artery involvement. Obviously, her coronaries were clear, but so I really think every cardiac finding is explained by the high blood pressure and the chronicity of it. And you just wonder if she has an inflammatory milieu, and that's why her pericardium looked a little bit inflamed. But that's the primary driver, I think, is some form of arteritis.
Thanks a lot. And I want to ask, like, in order to make a diagnosis, would you say that this would be enough to make a final diagnosis, or do you say we also need some biopsy for, especially if we hear something like aortitis? Like, I was thinking of differentials, like where also infectious causes that can cause something like aortitis. That's why I wanted to ask you.
Yeah, and like I said, I'm very comfortable. I always tell patients, I don't make things up. If I don't know the answer, I'm going to find you the answer. I would have to read up or talk to my friendly rheumatologist on I've seen one case of Takayasu's in my life. It was actually very interesting because it was a woman who was referred for heart transplant because of multiple valve surgeries, because of aortic and aortic valve and aorta surgeries, that she'd had so many that she ended up with a cardiomyopathy because of, honestly, and it wasn't until a pathology specimen of the fact that her valves kept failing when they replaced them and no one knew why, that they found out that she had Takayasu. So I don't know how you make it in real life. And that's something I would want my friendly rheumatologist to tell me.
Thank you so much, Dr. Kittleson. That was amazing. Then, Dr. Maulin, we are very excited to hear what the final diagnosis of this case is.
So Dr. Kittleson got it exactly. So the imaging was consistent with a medium to large vessel vasculitis, Takayasu arteritis, which is then complicated by myopericarditis, causing acute decompensated heart failure. And just to answer your question, I think imaging, from what I've read, imaging is sufficient to make the diagnosis.
Thank you so much. That was an outstanding case presentation. Maulin, I also wanted to ask you what you learned from this case.
I think the most important thing is Dr. Kittleson was talking about is, the patient comes in with acute decompensated heart failure symptoms, and sometimes we tell ourselves it's enough to just, diurese and try to get the blood pressure down, but really we have to find the underlying cause. And whether it's a rheumatologic phenomenon, which is rare, or any other cause, we really have to dig deep and find out why that patient is in heart failure, and reaching out to our consultants for that case. So I think that was kind of the most humbling part of this case. I saw this patient when I was an intern, and so I think this one has really stuck with me.
Thank you so much. And was there anything about the hypercortisolism that this, so any explanation for it? Because there was also these thrombi, the hypercoag. So did you have any explanation for it?
The best explanation for the hypercortisolism was just a stress response. I don't know if that's the correct one, but that was kind of what the consensus was at the time.
Thank you so much. Then I would like to ask Dr. Kittleson for her reflections on this case. And also, yeah.
I mean, such a good case. And, one way, okay, I'll give you 3 reflections. Number 1, remember to organize your differential diagnosis by pathophysiology and etiology. Organize your differential diagnosis to get to etiology through pathophysiology and anatomy. So try to be regimented in that way, and try to figure out which is the most concerning symptom that I really want to focus on when I'm trying to explain something. The second thing I'd say is, patients don't read textbooks. There's going to be a lot of red flags, or red herrings. There's going to be a lot of distractors in the way. Like, I still don't know exactly why she was scratching her legs a lot. Maybe we'll never know. I don't think Takayasu's gives you skin findings. So you have to always go by the thing that's the most abnormal when you're trying to work on your differential. And so here it started with the shortness of breath. as the most abnormal symptom. And then the other things were just kind of like, we need to slot them in somewhere. The second most abnormal thing was the blood pressure. We honed in on the blood pressure. The third most important thing was that cortisol. Okay, we went on a little bit of a wild goose chase to it, but that's actually okay because we came back to where we started with the imaging study that then brought out the Takayasu's. And I think you're not going to go wrong. My third reflection would be, you make your consultants work for you. You don't have to know the right answer, but you've got to know who to ask, and you have to know what to ask. And it could have been that you pinned down that friendly endocrinologist and he said, please don't look at me about that cortisol. That's so clearly a stress response in my decades of experience. And then you go to your rheumatology, you'd be like, well, this ESR CRP are so high. I know you get really irritated when I consult you for really high CRPs and ESRs, but something's not right. Help us put it together. So I think that those are the 3 points to keep in mind, where you don't even have to know the right answer, but you'll get there. And every case is a teaching case. So when you come up with a patient with a really weird diagnosis, delve into the chart, figure out how the treating clinicians came to that diagnosis, and then that will serve you as a good lesson the next time you happen to see a patient with that constellation of findings.
Thank you so much, Dr. Kittleson. That was so inspiring to hear. What I also wanted to ask you is, because this is cardiology and this patient presented with heart failure, I have to say, I never heard of vasculitis causing something like myopericarditis. That's why I wanted to ask you whether you could explain how this vasculitis is leading to heart failure.
I don't think the vasculitis did it so much as the hypertension. I really do think this is a hypertensive cardiomyopathy, and I think if you treat her with antihypertensives, and I don't even think treating with steroids is going to improve a lot of her hypertension, because I think she's got renovascular hypertension from some kind of kidney infarction. She's basically like a functional renal artery stenosis or fibromuscular dysplasia or renovascular hypertension. So I think the thing that's going to make her heart better is not the steroids you're going to give her to prevent horrible aortitis and brain stuff. It's going to be the antihypertensives you give her. And with adequate control of blood pressure, you can absolutely see normalization of cardiac function in a hypertensive cardiomyopathy. The fact she's not really dilated, I think, is actually a good sign that maybe she could be on the road to recovery potentially in that situation. So my sense is it is the inflammatory milieu that happened to cause this perimyocarditis, which back in the olden days, we didn't do MRIs in every single patient who walked in the door. So who knows what we were missing, what the true denominator of that type of inflammation response is. It's not something I would track. And so even carditis can be described in other vasculitis, I don't know how actionable that is, because the underlying causes treat the inflammatory arteritis. I wouldn't track an MRI findings for her perimyocarditis business, but I would treat her blood pressure.
Thank you so much. And also, Dr. Maulin, what I wanted to ask you is, how long did it took you to get the diagnosis in this patient, and what did you do management-wise?
So it took at least I think 5 or 6 days for us to get a diagnosis, which you all know in hospital time is a very long time. And actually, this patient's diagnosis was, her hospital stay was complicated by she was given captopril initially, and that dropped her blood pressure too much. She went into cardiogenic shock, went to the ICU, was on inotropes for a while in the ICU, and then eventually ended up doing well. She eventually got treated with steroids. As an outpatient, got treated with methotrexate, and then also got a renal artery balloon angioplasty. And to this date, she's still following up, and she's doing well. Her EF has recovered to 60%. Her blood pressure is well controlled.
It's I'm interested that they did the renal artery, because I would have assumed she'd had such distal stuff also related to maybe embolic phenomenon or small things, kidney issues. But this is the happiest ending you could hope for, that treatment of blood pressure improved her heart, treatment with immunosuppressive prevented further arteritis complications.
Thank you so much. And another question would be, did you do some kind of brain imaging? Because this patient also presented with lightheadedness, this headache, and this vision changes.
Yeah, she got an MRA of her brain, which was actually completely normal.
I mean, just goes to show skin findings, brain findings, they can all be red herrings. Maybe it was just the high blood pressure
Yeah.
that made her feel crummy.
Yeah.
Thank you so much. Then I would also ask both of you whether you want to share some final thoughts with the audience.
Know who to ask the right questions to, know the right questions to ask. That's mine.
And I'll say I've been lucky enough to work with Dr. Kittleson for going on 6 years now, and of course, every time I work with her, I learn something new. So it's great to be with you again, Dr. Kittleson. And I love your book, and I especially love the part about you learning French as a kid because I'm trying to learn French now. So it was very inspiring.
Oh my gosh, amazing. Well, I think of all my fellows as my children for life. So I might be your attending for a few years, but I'm your mom for life, Maulin. So you'll keep in touch.
Thank you.
Thank you so much, Maulin, for this amazing case presentation. I learned so much and for all the reflections. And yes, Dr. Kittleson, you're such a gifted teacher and outstanding educator. I always learn so much. Thank you so much for taking your time. You know, that was phenomenal. And that was just inspiring hearing you thinking through this whole case and also seeing how humble we always have to stay in medicine. That's what I love the most. So thank you so much.
Amazing. Thank you.
Then I would say bye to everyone and then hope to see you again soon. Bye, everyone. Thank you.
Bye.
Thank you.
Thank you so much.